Hello. Today we are talking about neonatal presentations of metabolic disorders. As neonatologists, we may only manage a handful of these inborn errors of metabolism during our careers. However, because early intervention directly dictates neurodevelopmental outcomes and survival, a high index of clinical suspicion is mandatory for any critically ill newborn presenting without a clear, definitive diagnosis. Today, we will step away from merely listing individual conditions and instead focus entirely on a systems-based approach, mapping classic and uncommon clinical presentations to their underlying biochemical errors. Let's begin with our primary biochemical axis, differentiating severe anion gap metabolic acidosis from primary respiratory alkalosis. An increased anion gap metabolic acidosis indicates the accumulation of non-volatile organic acids or severe lactic acidosis. This is our classic signature for organic acidemias like methylmalonic acidemia, or MMA, and propionic acidemia, or PA. Conversely, when you look at a blood gas and see a primary respiratory alkalosis, a pH greater than 7.45 with a low PCO2, your immediate top differential must be a primary urea cycle defect, such as ornithine transcarbamylase deficiency. This severe hyperammonemia drives a central stimulation of the respiratory center, causing profound tachypnea. Always cross-reference these findings with blood urea nitrogen. A remarkably low BUN is a classic indicator of an upstream block in the urea cycle. Remember, if fatty acid oxidation defects are in play, you will typically find severe concomitant hypoglycemia. In these specific scenarios, hold all lipid administration immediately until a definitive diagnosis is established, as adding lipids can be catastrophic. Moving to the neurological system, our biggest clinical trap is confusing an inborn error of metabolism with hypoxic ischemic encephalopathy. While HI neonates are typically symptomatic from the exact moment of birth, infants with metabolic disorders characteristically experience a clear, asymptomatic, normal window before rapid deterioration occurs. However, be aware that primary mitochondrial disorders can cause a significantly reduced physiological tolerance to labor stress, meaning a metabolic infant can present depressed directly at birth, perfectly mimicking an acute intrapartum event. When evaluating neonatal seizures, if your brain MRI shows no structural anomalies or acute ischemic injury, look closer at the EEG. A burst suppression pattern should strongly push metabolic etiologies to the top of your list. For suspected storage diseases, order a peripheral blood smear. Looking for vacuolated lymphocytes can provide a rapid, bedside diagnostic clue. Finally, do not overlook distinctive odors during a metabolic crisis, such as the classic sweaty feet odor of isovaleric acidemia or the boiled cabbage aroma of tyrosinemia. A metabolic crisis frequently leaves structural clues across multiple organ systems. From a cardiac perspective, left ventricular noncompaction should immediately flag Barth syndrome. If you are looking at an aggressive, infantile hypertrophic obstructive cardiomyopathy, maintain a low threshold for mitochondrial disorders or Pompe disease, the latter of which can reveal a characteristically shortened PR interval on an electrocardiogram. Long-chain fatty acid oxidation defects and propionic acidemia lean heavily toward dilated cardiomyopathies. An ophthalmologic evaluation can be a massive diagnostic accelerator. Finding corneal clouding points directly to mucopolysaccharidosis, while a cherry red spot screens for Niemann-Pick type A or galactosialidosis. Skeletally, we look for proximal rhizomelic limb shortening or stippled epiphyses, which are classic hallmarks of peroxisomal biogenesis defects like Zellweger syndrome. When these are paired with dysostosis multiplex or coarse facial features, you are looking at an advanced lysosomal storage disorder. In the NICU, metabolic conditions account for up to 54% of all cases of neonatal liver failure. Galactosemia is a true medical emergency that can present within mere days of starting breast milk or lactose-containing formula. Look for the classic triad of rapid jaundice, hepatomegaly, and a severe coagulopathy out of proportion to general sickness. These infants have an incredibly high risk for Escherichia coli sepsis. If you suspect galactosemia, check the urine for reducing substances. A positive test in the absence of glucosuria is a major red flag. Stop all breast milk and lactose formula immediately and switch to a soy-based option pending enzymatic verification. For infants presenting with recurrent, acute episodes of liver dysfunction, severe lactic acidosis, and hypoglycemia that rapidly corrects with a simple dextrose infusion, consider hereditary fructose intolerance. Although this typically manifests later, be vigilant. Some specialized infant formulas contain fructose or sucrose, which can trigger an uncharacteristically early neonatal crisis. One of the most dangerous phrases in neonatal medicine is, "the newborn screen was normal." We must completely dismantle this false sense of security. A normal newborn screening result does not rule out a metabolic disorder. First, an infant's analyte levels may simply have hovered just outside the rigid state cutoff metrics at the time of collection. Second, the vast majority of inborn errors of metabolism are completely absent from standard state screening panels. Mitochondrial DNA depletion syndromes, congenital disorders of glycosylation, disorders of pyruvate metabolism, and the vast majority of cofactor deficiencies responsible for neonatal seizures are completely invisible on a routine newborn screen. Furthermore, keep maternal biology in mind. Maternal conditions can cross the placenta, altering neonatal analytes and yielding false positive results, such as a false positive low-free carnitine secondary to an undiagnosed maternal primary carnitine deficiency. To close this lecture, let's establish our emergency stabilization playbook. When an infant is in a suspected metabolic crisis, you cannot wait days for a specialized genetic or biochemical panel to return. You must treat the patient immediately. Our primary goal is to arrest catabolism and actively promote anabolism. This requires aggressive fluid resuscitation and the immediate placement of a central line to safely deliver high-concentration dextrose, typically greater than 12.5%. If hyperglycemia develops as a result, do not scale back the dextrose. Instead, initiate an insulin infusion to force the infant into an anabolic state. Concurrently, initiate nitrogen scavenging therapy with intravenous sodium benzoate and sodium phenylacetate to bypass the blocked urea cycle. If the ammonia levels are refractory or severely elevated, skip standard medical management and move directly to continuous renal replacement therapy or hemodialysis to rapidly clear the neurotoxic load. In parallel with this stabilization, utilize modern rapid diagnostics, specifically ultra-rapid whole exome or whole genome sequencing, which can deliver a definitive diagnostic yield in up to 50% of our critically ill NICU population. Thank you.